practice, we have to remember that vital signs, blood pressure, respiratory rate, and pulse rate, right? Not so much temperature, pre-hospital environment. In the hospital, you can add part of the temperature. There do some other assessment things in here that they may call vital signs, but we look at that as we go along. Okay, so when we look at getting what's called a baseline set of vital signs and subsequent vital signs, so you get a baseline, you get the first set of vital signs. That sort of gives you a foundation or a base to go off. Very important before you start your treatment to get a baseline set of vital signs, and then after that you get subsequent vital signs. This tells you a lot what's going on in the body. You primarily, blood pressure is one of the last things you sort of look at. When EMT-wise, you look at the heart rate first. It goes rate, rhythm, pressure. Since you guys don't deal with the rhythm, then you would look at rate and then pressure. The heart rate will tell you quite a bit of information about what's taking place with the patient. A tachycardia could tell you that the patient's dehydrated. It could tell you that they have anxiety. It could tell you that they're bleeding. So quite a few things that the rate alone will tell you. The blood pressure you have to be careful on because of the compensation that we'll talk about during shock, and may get into a little bit here. But we look at pulse, respiration. These are things. Jeez. These things you get into here with capillary refill, skin temperature. Those are, you can get all that right when you go to check a pulse. But a lot of times, you touch the patient, they're warm. Then you look, use that sense there, and then they're pink, and they're not diaphoretic, so they're dry. Check the pupils for pupillary response. Anybody remember what they're supposed to be? Pupils are, it's the acronym.
Equal and non-reactive pearls, right?
Yeah.
Equal and non-reactive to light, or reactive to light.
Right. Pearl, P-E-R-A-L. Might be an extra R in there, stands for round, but pearl.
What?
That's not right. Pupils equal reactive. Oh, I'm having a stroke.
It's an A.
E-E-R-A. Pupils equal and reactive to light. That's right. Pupils equal and reactive to light. So when you shine the light in it, they constrict. When you move the light away, they dilate back equally on both sides. So pupils pearl, pupils equal and reactive to light. Then of course the blood pressure. And what we look at these, when we look at this, we get the baseline, then we set out trends. So we start trending those vital signs to let us know what's taking place in the body. Gives us good indications. The pulse, we're all familiar with the radial pulse by now. One on the thumb side, you would palpate the radial pulse. That is the primary pulse in a conscious patient. The carotid pulse is the primary pulse point in an unconscious patient. And then the brachial pulse between the bicep and tricep is the primary pulse in an infant, right? So we check this. At the pulse, you can't feel blood moving through there until you put pressure on it. Let's see who remembers this. When we put pressure on the artery, what does that cause? What type of blood flow? Yeah. Starts with a T. Right, turbulent blood flow. You can't hear or feel smooth blood flow. You have to place some pressure on it, just like when we inflate the blood pressure cuff, it creates turbulent blood flow. In other words, it sort of swooshes along. That's what you feel. So when you feel for a pulse, like in the radial pulse, you're putting pressure on that artery and then pushing that artery up against the bone. And that is causing turbulent blood flow. And that's why you feel that sort of throb in there, those waves of pulsation. So what you would do, you typically they stay away from the thumb, take the two fingers, apply a light amount of pressure. If you put too much pressure on someone that has a weak pulse, you're going to occlude the pulse. You won't be able to feel it. A lot of times, especially with you guys, when you're trying to check each other's pulse, radial pulse, you may have to bend the hand down like this. When you bend the hand down, it pushes the artery more towards the surface, so you bend the hand down, and then it makes it easier to palpate the pulse through there. And we know that when we check the pulse, right, we check it for, we want beats per minute. So what we do is we count. You can count for a full minute, or you can count for 15 seconds and multiply times 4, right? Or 30 seconds and multiply times 2. On an infant or child, you want to check the heart rate for the full minute. Infant and children normally have an irregular heart rate. It's called a cardiac dysrhythmia, and it's normal for a child or infant to have that. When they breathe in, their heart rate goes up, and they exhale, it goes down. So you want to count that for a full minute to get an accurate beats per minute. Anything above 100 is considered rapid. Anything below 60 is really considered slow. However, you have to take the patient's condition and time in there. What are they doing at the time? You know, did they just get finished running? Are they in a car wreck? Their heart rate's going to be very rapid, correct? So you got to take that. Or did they just wake up out of bed? Have they been sleeping? Their resting pulse rate may be low. But for a norm, 60, below 60 is somewhat slow. And then above 100 is considered fast. So when we go out for our primary assessment, remember we check for a presence of a radial pulse and then just sort of try to judge, is that slow or fast? Here we're actually counting the beats and getting a beats per minute. Now, some people normally have a very slow heart rate. That's not abnormal for them. Like you get a lot of marathon runners and people in this really good shape, their resting heart rate is usually pretty slow. So to get below 60 is okay if that's their norm, if that's normal for them. Anything really, like I said, it's over 120 beats per minute, unless they're exercising, is a problem. There's a problem somewhere in there. And then 50 beats per minute is fairly slow. On both sides of this, what is the primary problem with it? What is the problem with it being too fast or too slow? Exactly. The cardiac output. If it's too fast, you get a decrease in refilling time, correct? Too slow, you get the same result, except for the heart's just not pumping fast enough to produce enough cardiac output. Mainly if it's beating too fast. The atrium, they don't have time to refill, so the ventricles don't refill properly, and then the stroke volume is decreased. What's the average stroke volume? Yeah, about 70 milliliters. So the stroke volume is the amount of blood that is pumped out of each chamber of the heart. Each time out of the ventricles. So every time the ventricles contract, the average stroke volume is around 70 milliliters that come out. If the heart rate is elevated too much, then it doesn't get enough refilling time to refill the ventricles, so you have a decrease in stroke volume, which results in a decrease in cardiac output. What's the formula for cardiac output? Man, it must be nice to be young. Have that young memory. Stroke volume times heart rate. So you note that when you get stroke volume times heart rate affects the stroke volume, affects the cardiac output on both sides. So if we watch this rate primarily for that. A fast heart rate could also, people in pain can have a tachycardia. Most of them do. Their heart rate shoots up. When we look at the pulse rhythm, it should be regular. You should have a regular pulse. An irregular pulse in some people may be normal, but it's normal for them. The norms, when we check, is it regular or irregular? So we look at the beats per minute, and then we look, is that pulse regular or irregular? Later we'll learn some things when we get into cardiac emergencies. We'll learn some things about the irregular pulse that will be more prominent. But for right now, all we're looking for is if it's regular or irregular. And remember, in small children, it's going to be irregular, and that's normal. So that's not a problem. The other thing is the strength or the force. How strong is that pulse? What we have here is we have a +1, +2, or +3. The +2 is normal. That's a normal pulse. And how you judge a +2 is that you would take the radial pulse, put a normal amount of pressure on it. Let me back up. Take the radial pulse and push down as hard as you can, and you can almost occlude or stop the pulsation. But you just can't quite stop that pulsation. Go ahead, try it. You look so interested. So you can almost stop the pulsation right there, but it's still pulsating just a little bit, right? So that's a +2. That's normal. A +1 is considered a thready or weak pulse. So you would do the same thing. You would find the radial pulse and push down, but on a weak pulse, you're able to stop that pulsation. And that means that they have a weak pulse. We don't know why yet. We just know that they have a weak pulse. Usually it's due to the heart not working good enough. Something's wrong with the heart. It's not contracting with enough force. Maybe hypovolemia, something like that, going into shock. The other pulse is a +3, and it's considered a bounding pulse. So you do the same method. You push down, but when you push down, you're not stopping anything. It's like jumping off the charts. So it's bounding. You would probably have a bounding. I would have a bounding pulse if I was doing like a monster, and you check my pulse. It would be bounding. Or caffeine induced or something like that. So this is important because it tells you the condition. It leads you into the condition of how the heart is working. If it's normal, if it's heart working too hard, a bounding pulse tells you that the heart's working too hard. A +1 tells you it's not working enough. Something's wrong. It's a weak pulse. Is everybody good with those? +1, 2, and 3. And we talked about the radial, brachial, carotid. Remember the femoral. CPRs, you check the femoral artery quite a bit, but primarily the carotid pulse. Infant brachial, infants less than a year, between the bicep and tricep. Here's a good picture of the carotid pulse. A lot of people, when they go to check a carotid pulse, they get too far over lateral and they get into the muscle. Everybody feel this muscle that's on the side of their neck? A lot of people get in that over there. You find that the thyroid, and just sort of roll off the thyroid in between that muscle, and the thyroid, and that's where the carotid pulse is. And it's the primary pulse in an unconscious person that we would check. So if you want to wait the 30 seconds, you can multiply by 2, or 15 seconds multiply by 4. So it's fairly easy. We'll want to practice these as easy as it is. Okay, you'll want to practice checking each other's pulse. Everybody's going to have a different rate and force and rhythm. Okay, so we want to look at that. We want to practice. Respirations, inhalation and exhalation, is measured the same way. You measure it for 15 seconds, multiply by 4. What we're looking here is it normal? Is it labored? Are they having trouble breathing? Can you see that they're using the accessory muscles and they're having trouble breathing? Shallow? Are they not getting a deep breath in for some reason? Could be pain. Most of the time it is pain. They're in some sort of pain. They can't get a deep breath, or they're breathing erratic or irregular. Because we know that you should have equal and symmetrical rise and fall of the chest, and it should be a regular rate and rhythm. 12 to 20 is the normal rate, respiratory rate. What's the normal heart rate of an adult? Huh? No, normal heart rate, range. 60 to 100? Why is it 60 to 100? No, there's a reason. It's 60 to 100 because what gives us give you a hint. What gives us that primary pace that sets the heart rate? Right, which is what?
Wait, what did you say? The isn't it the essay mandatory part?
Right. What did you say? Go ahead and say it so everybody can hear it.
Oh, it's the primary. Oh, the essay node.
Right, the SA node. The primary firing rate of the SA node is 60 to 100 times per minute, right? So that's the normal range of an adult, 60 to 100 times per minute. Respirations, 12 to 20. Most people breathe 16 to 18 times per minute. Anything below 12 is considered hypoventilation. Anything above 20 would be what? Hyperventilation. I mean, we'll get into the respiratory emergencies in a few class periods, but these are measured the same. You need to make sure, I know it sounds strange, but you need to practice the respiratory rates because it's difficult when you're looking at someone with a hoodie on or something like that. It's a little bit more difficult to get a good respiratory rate. They will, when they ask you to do a set of vital signs in the ambulance, they will want an accurate respiratory rate. They just don't want you guessing. So you have to practice, and you want to know what looks normal and abnormal. So give you some time to sort of stare at each other's chest and count respiratory rates. It's very strange. You've got to get sort of used to a way of doing it. What I recommend that you do, so that you're not just staring at each other, is, can I borrow your wrist? You check the radial pulse for 15 seconds, right? Now, I'm going to tell her that if I say, I'm going to check your respiratory rate now, the patient will automatically start breathing faster. So what I do normally is I'll check the pulse rate, but sick people like to be touched for some reason. Maybe not young people, but older people do. So what I would do is I would check their pulse rate, and I'll have my hand on their back like this. And I'll count 15 seconds for the heart rate, and then I'll just continue. I'll stick that number in my mind, and then I'll continue on the respiratory rate, and then I can feel the rise and fall, the back. So I can feel the respirations, and I can count that way. even that method is somewhat, takes a little practice. On the ambulance, if you just can't get used to it, use your stethoscope. But what is the norm when someone puts a stethoscope to your chest? Yeah, you go. And you're telling them, breathe normal, and they go, no, really, breathe normal. And they'll keep doing that because that's what they've been programmed since, they were eating dirt. That they would breathe in when the doctor puts the stethoscope on their chest. So you sort of look and judge that. If they're in respiratory distress, you need a very accurate respiratory rate. A lot of times I would just say, you're breathing 16 to 18 times per minute. You're in the normal range. You're breathing normally. But you want to practice on getting that normal rate. It's a little bit more difficult than the pulse rate. We'll talk about hyperventilation, hypoventilation during respiratory emergencies. There's a number of things that take place in the body during each one. So we won't really go into that right now. We'll just look at this and say, if they're hyperventilating, there's a problem. If they're hypoventilating, there's a problem as well. And that's the two things that we'll be fixing during respiratory emergencies. The skin, warm, pink, dry. So everybody's warm, pink, and dry. By now you should have seen people who are pale, right? You can look at most people, you get that good general first impression, you go, man, you don't look like you feel good. You look a little pale. Or flushed. Maybe their blood pressure's up and they're flushed. But skin on the norm is supposed to be warm, pink, and dry. When it's not, when it's pale, there's probably a circulation problem. Cyanosis tells us what? Lack of oxygen. Red or flushed. They could be hypertensive, have an allergic reaction. I don't know. Usually hypertensive through here. Jaundice. What would call them to be yellow? Yeah, the liver. Something's wrong with the liver. They're in liver failure. They're the yellow man. And it's weird looking. They'll be all yellow in the whites of their eyes. Either if they haven't turned yellow yet, they're getting all yellow, jaundice in the whites of their eyes. They're real. You see these wide eyes and this yellow face. It looks sort of weird.
That's so common in babies.
Belly Reuben or something like that. They're missing some belly Reuben.
What's that?
I don't know. I just made it up. Capillary refill. It's another thing you would check. It's very good in young children. Older adults, capillary refill is not so good. We get all this vasoconstriction, diabetes, all these different things, cold hands, warm hands. It's just not a very solid thing to check for perfusion in an adult. Still use it, but in children it works very well. Capillary refill, remember, is what's the normal capillary refill?
2 seconds.
Huh?
1 to 2 or 3 or 2 seconds.
2 seconds. So you would push down on the fingernail bed, let it blanch or turn white, and then let go, and that should refill within 2 seconds. If it doesn't refill within 2 seconds, it's considered delayed. Then we go into trying to find out why the capillary refill is delayed. There could be a number of things. This will work as well. You can do capillary refill for like CMS checks. For circulation. But for some reason it's delayed, and those are the things, as we move through the chapters, we'll figure out this would cause delayed capillary refill. So the normal is 2 seconds. Anything else is, you can just document delayed. We already talked about the pupils, and I think it gives a picture. Yeah. But when you shine the light in, the normal response is you shine the light in the eye, and the light constricts, and then you move the light away, and it goes back to its normal size, and then you come over here and shine the light, and it constricts, and it goes back to its normal size. On most of the flashlights that you use, there's a little eye gauge. I have to use that. I can't tell. It's measured in millimeters, and I can't tell just by looking what millimeter. I have to sort of go, 3 millimeters. Look at my gauge, and then look at the pupils. There's a number of different cases here what would cause abnormal pupils. I don't know how well you can see this, but see how constricted those are? If I saw that, I'd say, opiate overdose. Took a little bit too many drugs there. Because with opiates, the pupils constrict. This, on the other hand, these bicodilated pupils, just the opposite. Amphetamines. Taking some amphetamines or something's causing those pupils to dilate like that. And it's usually drugs when you start looking at that. Here we get unequal pupils. See how this one's constricted and this one's dilated? We'll learn about that. This is called a blown pupil. It's just the slang term for it. So you have a blown pupil. What's this? Right pupil's blown. That's a sign of a head injury. Actually, it's a sign of brainstem herniation. That's where the brainstem's going through that hole in the bottom of the skull.
It's not bad, it's not light.
No, it doesn't react. So,
Would you like that much of a difference? Like actually,
yeah, it's freaky looking.
like, 'cause I've seen it like to where like guys that have concussions, like they like react differently, but they're not like that.
Yeah, they're night and day. One's real constricted and one's dilated, and that's a positive sign of a head injury. In trauma, you could have something medical going on, but in trauma, that's a positive sign of a head injury, and it's usually brainstem herniation. This patient here is in a lot of trouble with that blown pupil.
And besides drugs, like what would be another cause for the constricted and dilated pupils? Or is it just drugs?
Mainly just drugs. Different types of drugs. Amphetamines, opiate-based drugs, like morphine, Dilaudid, heroin. Yeah, you get them really constricted down. The last overdose I ran on her pupils were almost shut. I mean, they were just pinpoint pupils. It's what you would actually call these. Pinpoint would be the term you would write down. And she'd overdosed them. Something, can't remember. So, that's a good question about other things. Google that. I'm not sure what could cause it. Google's your friend. All right, and the last one we look at is blood pressure. We know that a typical normal pressure, they range at 120/80. Your pressures won't be that high. Mama's boy probably will, but yours won't. You won't have a 120 blood pressure. Yours is going to be more in the line of 100, if not a little bit less. So it just gives you sort of a normal range. There is a huge laundry list of things that could cause hypotension and hypertension, low blood pressure, high blood pressure. We'll talk about that when we go into cardiac emergencies, circulatory emergencies. You use the blood pressure cuff that you guys know about. You've used them before. All right? And then however you say that, when you see this big word here, that equals blood pressure cuff. You may know how to say that? Yeah.
Big mom and then manometer.
Now you know why we call it blood pressure cuff, right? Okay. So the goes up off the elbow in the mid arm, all right, with the, and you'll see this, maybe there's a better picture. Nope. There's a little arrow here. That arrow should be in line with the brachial artery. That's where you're going to get the most accurate blood pressure. You put it on the arm where when the patient can lower their arm, the blood pressure cuff won't fall off. But you don't want it on so tight that it causes vasoconstriction. You don't want to put it on there so tight their blood vessels start to pop up. Alright? So firm but not too tight. If it's too loose, it'll fall off. You have to have the right size cuff. They make an adult cuff. They make a large adult cuff. They make a thigh cuff. They make a small adult cuff. They make a child's cuff and an infant's cuff. So you get the right size blood pressure cuff. Your parents bought some this year for us, because we haven't done blood pressures in here. So now we have a child's cuff, because an adult cuff's too big for you. So you're just too small. Nothing personal. You know, but so you would use a child's cuff to get a more accurate blood pressure.
But how does it feel like really big compared to CrossFit?
It's good. And there's a lot of people out there like that. You don't have a cuff that really fits them. You can take on most people, you can take that are that large, you can take a regular adult cuff, and this is what I usually do instead of getting a large cuff out. I just put it on their forearm and take the blood pressure there electronically. You can't do it manually, but electronically I'll put the blood pressure cuff on the forearm and just take it, with the note that it's going to be a little higher than normal on the forearm. So it might be 120/80 here, it might be 130/90 here on the forearm. So it's going to be a little bit more elevated. The smaller artery that you're using to take the blood pressure on, the higher the blood pressure is going to be. But yeah, just put it on the forearm. I put it on the forearm, their leg before their calf. You know, some people are really like Free Willy size, you know, and you can't have any sort of blood pressure cuff to fit them. Just doesn't wrap around. So make sure it's lined up with the brachial artery. Auscultating a pressure is to listen. So when you take the stethoscope, we're going to do palpated pressures in here first. That way it gives you sort of a range to go by. But on most adults, you can pump the blood pressure cuff up to, 150, 160, and it'll be okay. But we'll do palpated pressures first, so we don't hurt anybody. But so you pump the blood pressure cuff up, let's say to 150, and you put the stethoscope there, and you start releasing the air, and immediately you hear a sound. What do you need to do? Huh? Yeah, you need to pump the blood pressure cuff up more, where you don't hear a sound. Let's say 160, you pump it up to 160, you put the blood pressure cuff over where the brachial artery comes out, and the needle's over here. You slowly start to release the air, and the needle starts to fall. Alright? It'll start bouncing. Don't let the bouncing fool you. Start bouncing, and then all of a sudden you hear the ba-boom, ba-boom, ba-boom sound, right? The lub-dub sound. The first sound that you hear is the systolic pressure. So let's say you hear the first sound at 140, all right? And you're going to hear that sound go ba-boom, 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 ba-boom. And then you hear silence and the needle will just drop. The last sound that you hear is the diastolic pressure. So let's say it was at 90. So 140/90. So the first sound that you hear is the systolic pressure. The last sound that you hear is the diastolic pressure. If you miss the last sound, just pump it up again to where you can hear it, and then watch the needle as it drops in the last sound. So pump it up, 160, it starts coming across, needle slowly release the air, starts to bounce a little bit. Boom, boom. Note that first sound, systolic pressure. you hear the beating, you hear the heartbeat sound, and then it goes away, and the last sound that you hear is the diastolic pressure. Everybody good? Y'all remember that? So not too bad, not too hard to do. The thing with auscultating a blood pressure is that you have to get used to what you're hearing. Fortunately, we have the arm over here that is loud. It's louder than the normal pressure, the normal sound that you would hear, and it helps train your ear a little bit. So we'll use the arm quite a bit when we're working on auscultated blood pressures. The other way to check is by palpation to touch. So you put the blood pressure cuff on, you feel the radial artery, palpation, touch, and then you start pumping up the blood pressure cuff until you can't feel the pulse anymore. Then you stop pumping up the cuff, slowly release the air, the needle will come over, the needle will start to bounce. So like a yellow light, it's telling you to get ready. The needle starts to bounce, and all of a sudden you feel the radial pulse come back. That moment that you feel the radial pulse, that's the number that you would record. That's the palpated pressure. It only gives you an average or an estimate of the systolic pressure. So let's say the palpated pressure was 110. You would note that 110 over P, or you could note that 110 pal. We do that first in here to sort of get that range. Alright? So if their palpated pressure is 110, we don't have to pump the blood pressure cuff up to 160. We can pump the blood pressure cuff up to 130 and we'll be okay. So now you pump the blood, now you got this palpated pressure. Now you can pump the blood pressure cuff up to 130, put it on, get an auscultated pressure, pump it up about 130, and be safe that you don't injure the patient's arm. So we do palpated pressures first in here, so just as a safety deal. So you know what an estimated blood pressure is and know how much to pump the blood pressure cuff up. You can injure the nerves that run down the sides of the arm, between the tricep and bicep. You can injure those if you pump the blood pressure cuff up too much, and then the patient's not able to feel their hands anymore. So that's why palpated pressure is good. Of course, most everything's electronic now. You push the button. But even with electronic pressure, you have to watch that to make sure that it's not pumping it up too much. I've seen the electronic blood pressure cuffs pump up to 220. And the patient's sitting there going, "It's killing me." And so you have to stop what it's doing. For some reason, it's not picking it up, and it's inflating the cuff too much. So then, at that time, you have to do a manual pressure, right? Perhaps. Does everybody understand palpated method? Did y'all do palpated pressures? Okay, it's simple to do, so shouldn't take long to jump in. Use the right size cuff. Children, little babies typically don't get a blood pressure unless there's something really wrong. A lot of times I'll put on infants, I'll put it on their calf. Get a blood pressure down on their leg instead of their arm. But even electronic cuffs, you have the right size cuff you need to use. Not a lot of people get temperatures anymore unless you have a temperature problem. If the patient has fever, you want to get a temperature. If they've been out in the environment, like a hot environment, you want to get a body temperature the same way in a cold environment. You want to get a body temperature. Just do an oral temperature. Not too many ambulances carry the big fancy electronic thermometers like the hospital. They have the little cheapo ones like you might have at your house. But it still gives you a base, gives you sort of a baseline to go off of, even though it might not be totally accurate. Still gives you a number to adjust with. Oxygen, SpO2, we've already talked about, right? So it's part of the initial assessment. Make sure that you get a room air SpO2, and that's before you put the patient on oxygen. Put the meter on. Again, make sure that the pulse rate on the meter corresponds with the mechanical pulse that you're taking. And the norms, 90, 96, 95 to 100% is normal. They say a mild hypoxia, 91 to 95%, and then significant down in the 80s and severe 85. But again, it's all depending upon what the patient is. I've seen a patient that's hypercarbic, which means what? Huh? Yeah, they retain a lot of carbon dioxide. Emphysema patient, they're hypercarbic, and they were in the 80s right here, but no hypoxia, just a lot of carbon dioxide. So that would be a normal SpO2 for that patient. But normally, 95 to 100% in that range when you guys check SpO2s.
What would you do to have like the artificial nails for really people?
Yeah, you might have to put it somewhere else, like on a toe. They have fake nails. Most ambulances have the nail polish remover on there, but most of the women, when you break that nail polish remover out, they about have a cow. You know, you're about to remove that. I think it'd melt away that acrylic nail, so they don't really want that. So a lot of times I'll put it on a toe. If they have fingernail polish, that may or may not disrupt the SpO2. Just have to go. If it's a tape-on SpO2, you can tape it to their forehead or something. You can put it on anywhere that there's a capillary bed. Children, a lot of times, they tape it to their ear. So you're right. You just have to sort of, they have the big nails or the fake nails, you have to sort of mess around with the meter and see where you can put it. Sometimes you have to scrape off of the fingernail polish. The acrylic nails, the plastic ones that go on top, I guess, are difficult. Hopefully they don't have it on their toes. But you just move it around. Y'all don't put those on your toes, do you? Acrylic, fake toenails? No? Okay. So, look, shock, hypothermia, carbon monoxide poisoning will mess up the SpO2 reading. Diabetes, a lot of times will mess it up. People who are thyroid problems that are always cold will have the SpO2 won't read it very well. All right, so there's a number of reasons that it won't read. So you'll just have to sort of judge that on each case. It's not working because of this. Blood glucose is another thing that we check, or a D-stick, dextrose stick. When we talk about diabetic emergencies, we'll talk about that. We'll practice on each other. We'll poke each other's finger, do a dextrose stick. All right? And then on all diabetic patients, you would do a blood glucose. But on most all patients, you do a D-stick. Randy's rule to altered mental status is that you always do a D-stick on someone with an altered mental status. Always do a D-stick with someone with altered mental status. You pick up that patient from the nursing home. The nursing home says, oh, this is her normal mental status. What do? D-stick. Even though the nurse at the nursing home just told you that's normal for that patient, you always do a D-stick. So those are one of those steadfast rules to live by, because you don't want to take that patient into the hospital and where they're going to do a D-stick and they come back and say, hey, they're hypoglycemic. Why didn't you fix this? Right? So you've got to, any altered mental status, you always do a blood sugar. There's the meter. That's actually looks like the meter that I have too, but we'll mess around with those when we get into diabetic emergencies. You have the sort of the strips here that fit down in here in the bottom, and then of course the lancets that stabs the finger, gets the blood out. Yeah. Anyway, we'll look at it. Medical direction, we'll talk about more of that in diabetic emergencies. You don't need too much medical directions for blood glucose. It does have to be calibrated. So if it's not the glucose meter's not calibrated, it won't work very good. And then we'll go through all these steps later. Normal blood glucose, 60 to 80. You're getting more hyperglycemic at 140 or so. So this is a difference here. So we'll look at those 60 to 80. 60 is a little low. My normal, I would think, would be 80 to about 110, 120. But 60 to 80. You get lower than about 30, 40 or 30, the meter won't pick it up. It will just read low. And if you get above, usually 400 to 500, it's just going to read high. So we'll talk a lot more about that during diabetic emergency. Pediatric vital signs, just a quick note, because we'll go over those in pediatric emergencies. The thing with pediatric vital signs is when we go through the pediatric chapter, you have to learn those norms. Those norms are going to be very important for you passing the different tests.